Hello everyone, welcome to our lecture on neurogenic bladder, and this is part of our elimination concept for HCC. So let's get started. Alright, so a neurogenic bladder is a very complex condition where the bladder dysfunction actually stems from disorders of the nervous system. So it may be caused by a lot of different factors, things like a spinal cord injury, a stroke, spinal tumors, herniated vertebral discs, multiple sclerosis, or even different congenital disorders such as spina bifida or myelomeningocele. So these neurological disabilities essentially will disrupt the normal control of the bladder, and it results in a type of neurogenic bladder. And we have two primary types, either a spastic, otherwise known as an overactive bladder, or it may be a flaccid, which is otherwise known as an underactive bladder. So we're going to start with the spastic bladder, which again, also referred to as reflex or overactive bladder. So this condition is the most common form, and it's associated with upper motor neuron lesions, which are seen in patients with strokes or high-level spinal cord injuries, such as those in the cervical or mid-thoracic regions. So the problem lies in the failure of communication between the lower spinal cord and the brain. So when the bladder fills, the sensory signals that would normally alert the brain of fullness can't be perceived. However, because the voiding reflex arc remains intact, the bladder is still going to empty reflexively, usually oftentimes without the patient's conscious control. So this leads to things like incontinence and incomplete bladder emptying, which can increase the risk for urinary tract infections. Now, on the other hand, we have a flaccid bladder or underactive bladder. And this type results from lower motor neuron lesions, such as those caused by things like trauma, multiple sclerosis, or spinal cord injuries below the level of T12. So in this case, the bladder can't contract effectively to be able to empty itself, which leads to urinary retention and overflow incontinence. So sensory loss will often accompany this condition, meaning that the patient may not feel the discomfort despite the bladder becoming greatly distended. So this type of neurogenic bladder is increasingly recognized in diabetic patients due to the impact of neuropathy on bladder function. So an important concept to remember is that bladder control is influenced by both the autonomic and the central nervous systems. So early in life, the autonomic nervous system is going to govern reflexive emptying of the bladder, which is what we see in infants. Over time, the central nervous system is going to take over, which allows us to develop conscious awareness of bladder fullness and voluntary control over our voiding. So a neurogenic bladder disrupts this balance, leading to either a lack of storage function, such as what we see in spastic bladder, or it may lead to a lack of emptying function, which is what we see in a flaccid bladder. So in patients with a spastic bladder, the inability to regulate bladder activity means that it empties again on reflex, usually at inopportune times. So this lack of storage function makes it really challenging for patients to be able to maintain their continence. And on the other hand, patients with a flaccid bladder, which again is the inability of the bladder to contract, leads to chronic retention. So overflow incontinence can occur whenever the bladder becomes overly distended. And because sensory input is usually impaired, patients may not realize their bladder is full, which again can lead to other complications. So a critical point to understand is that the bladder is very unique in being controlled by both the autonomic and the central nervous systems. In a neurogenic bladder, this dual control, it becomes disrupted, which leads to the significant challenges that we see for patients. So proper management and intervention really depend on identifying the type of neurogenic bladder and understanding the underlying neurological damage to be able to provide appropriate care. So by recognizing these distinct pathophysiological mechanisms, you or me or all of us as nurses can better support patients in managing their condition, as well as reducing risk of complications like infection and improving their quality of life. All right, so now let's discuss some of the complications that are associated with a neurogenic bladder. So these complications can significantly impact a patient's quality of life and can require diligent management and intervention. So first, infections are a major concern. Due to urinary stasis, which is when the urine remains in the bladder for a prolonged period, bacteria have the opportunity to multiply, which increases the risk of urinary tract infections. Also, catheterization, which is often used to manage bladder emptying in these patients, can also introduce pathogens and further contribute to infection risk. Another potential complication is the development of renal calculi or kidney stones. So whenever urine flow is disrupted or incomplete, minerals and salts in the urine can crystallize and form these stones. These can cause significant discomfort and can lead to additional complications if they're not addressed promptly. Another complication is impaired skin integrity. It's also very common, especially in patients experiencing incontinence or those who are immobile. So continuous exposure to urine can lead to skin breakdown and can increase the risk of pressure injuries or infections. And lastly, urinary incontinence or retention can severely affect a patient's day-to-day activities and their emotional well-being. So incontinence occurs with spastic bladder, which is again where the bladder empties unpredictably, while retention is going to be more common in a flaccid bladder, which is where the bladder fails to empty fully. So both conditions can lead to a cycle of complications, infections, or kidney damage if it's not managed effectively. So as nurses, being able to recognize these potential complications allows us to develop a comprehensive care plan that address not only the physical, but also the emotional and social challenges that are faced by these patients. So preventing complications really requires proactive interventions, including things like regular bladder assessments, proper hygiene, and effective management of catheter use. Moving on to assessment, which plays a really important role in being able to diagnose and manage neurogenic bladder. So our assessment begins with basic observations like measuring the patient's fluid intake and their urine output. So these values give us insight into the patient's hydration status and their bladder functionality. One essential tool that's used in the assessment is the bladder scan, which is a non-invasive ultrasound device that helps measure post-void residual, or PVR, and this is the amount of urine that's left in the bladder after voiding. So this measurement is very important because patients who can't completely empty their bladder, again, are at higher risk for things like urinary tract infections due to urine stasis. So whenever it's used correctly, the bladder scan provides really accurate readings. However, you should note that accuracy can sometimes be impacted by different factors, such as the person using it and whether or not they're aware of how to work the bladder scan, and then also some physiologic factors, such as if the patient is obese. Then sometimes it doesn't work quite as well. The accuracy isn't as great. But the primary goal of using a bladder scan device is to avoid any unnecessary placement of an indwelling urinary catheter, which are the leading cause of chronic urinary tract infections. So in addition to getting a post-void residual, or PVR, a urinalysis can also help detect signs of infection or other abnormalities within the urine. So we also assess, along with PVR and getting a urinalysis, we're also going to assess the patient's degree of motor control and their sensory awareness of bladder fullness to determine the type and the extent of neurogenic dysfunction. Moving on to our diagnostic procedures. So there are several specialized studies that can be conducted to further evaluate bladder function. Urodynamic studies analyze how well the bladder stores and empties urine. A cystoscopy provides a direct visual exam of the bladder and the urethra. Different imaging techniques such as an IV pyelogram or a retrograde pyelogram, renal ultrasound, or a CT scan all allow us to assess the structure and the functionality of the urinary system. So with all of these combined assessments and diagnostics, we can develop an individualized care plan that addresses the unique challenges that each patient faces, which helps us, again, ensure better outcomes and reduces the risk of complications. All right, so let's talk about how we can manage neurogenic bladder. And this is usually done with a multifaceted approach. And while I say that, non-pharmacological interventions really play a central role. These strategies help to improve bladder emptying and prevent complications. So one of the first things we're going to discuss as far as non-pharmacological interventions go is facilitating or triggering techniques. And these stimulate voiding by targeting specific areas of the body. So for patients who have an upper motor neuron problem or like a spastic bladder, common methods include things like stroking the medial aspect of the thigh, pinching the area above the groin, or using digital anal stimulation. For men, Massaging the penoscrotal area and pinching the posterior glans penis can also trigger voiding. These techniques work by sending signals to the spinal cord, mimicking the sensation of bladder fullness. On the other hand, patients who have a lower motor neuron problem and have a flaccid bladder, these patients, some additional stimulation is going to be necessary to facilitate voiding. So two key methods are the Valsalva maneuver and the Creedon maneuver. So the Valsalva maneuver involves holding one's breath and bearing down as if to defecate or have a bowel movement. And this works because it increases the abdominal pressure to help expel urine. However, caution is needed for patients with spinal cord injuries when using the Valsalva maneuver because they may be at a higher risk for developing bradycardia due to that vagus nerve stimulation. And the Creed maneuver involves placing the hand in a cupped position over the bladder and applying gentle inward and downward pressure, which mimics a massage to be able to promote emptying. All right, our next non-pharmacological intervention is going to be intermittent catheterization. And this is really important because it helps manage urinary retention and prevent complications like bladder overdistension. So to begin, a urinary catheter is going to be inserted every few hours to drain the bladder completely, especially after the patient has attempted voiding techniques like the Valsalva or the Creed maneuvers. Over time, if the post-void residual, or PVR, measures consistently or shows less than 100 to 150 milliliters of urine, then the intervals between catheterizations can be gradually increased. However, it's very important that the patient does not go beyond 8 hours between catheterizations just to prevent urinary retention. For patients who require intermittent catheterization at home, nurses play a really key role in teaching proper technique to both the patient and their family members. So specialized appliances may be used to assist patients who have some limited manual dexterity. And for those who are unable to perform the procedure independently, then caregivers or family members are going to be trained to ensure safe and effective catheterization. It's also important to note that most patients during intermittent catheterization, particularly those with spinal cord injuries, may develop chronic bacteriuria. So this is just a condition that refers to the presence of bacteria in the urine, which is going to be often detected on a urine culture. However, treatment is typically unnecessary unless the patient exhibits signs of a urinary tract infection, such as things like fever or burning during urination. In older adults, confusion may be the only indication of a UTI, which really highlights the importance of why we need to have a very thorough assessment, especially with many patients who have urinary issues or are at higher risk for urinary tract infections. And lastly, intermittent catheterization should be paired with consistent scheduling of toileting routines or timed voiding, which we're going to talk about in a little bit more in depth on the next slide. All right, our last non-pharmacological intervention is going to be consistent scheduling of toileting routines. And this is also known as timed voiding. It's one of the most effective strategies for reestablishing continence in patients with an overactive or spastic bladder. So this approach really focuses on creating a predictable routine that aligns with the patient's natural voiding patterns and their daily activities. So the first step is to assess the patient's previous voiding patterns and to determine their daily routine. This information helps in setting up a toileting schedule tailored to the patient's needs. So at a minimum, patients need to be assisted to void at specific times throughout the day, including things like after they wake up in the morning, before and after any physical activity, and again at bedtime. And really, toileting should ideally occur every 2 hours during the day and every 3 to 4 hours at night. So this routine reduces the risk of overdistension and incontinence while helping the patient regain some control over their bladder function. So there are several factors that need to be considered to ensure the routine is effective and realistic. For example, the patient's bladder capacity, which can range from 100 to 500 milliliters, needs to be assessed by measuring urine output. Mobility limitations and restrictive clothing should also be addressed to make toileting easier and more accessible for the patient. So with this, we need to make sure that patients are always aware of nearby bathrooms and that they have access to a call system to be able to request assistance from nursing staff or their caregivers. All of this awareness really just reduces anxiety and it helps foster independence, making the routine much more manageable for both patients and their caregivers. All right, moving on to our pharmacological interventions, which are not commonly used for primary treatment for urinary elimination problems in neurogenic bladder. However, in certain cases, they can help play a supportive role in helping to manage symptoms. So for patients who have a mild overactive bladder, antispasmodics may be prescribed to help reduce incontinence and to help improve bladder control. So some of the common medications we see are like oxybutynin, which works to relax the bladder muscles, solifenacin, which reduces the urge to urinate, and tolterodine, which helps decrease bladder spasms and frequency. All of these medications are typically used on a short-term basis, and they need to be carefully monitored for their effectiveness and for any side effects. In the cases where UTIs are present, antibiotics are going to be the treatment of choice. Patients with symptomatic UTIs may receive a short-term antibiotic therapy using medications like trimethoprim or with sulfamethoxazole, otherwise known as Bactrim. These patients usually do well with these medications. And sometimes for patients who get a lot of UTIs, a pulse antibiotic therapy approach may be used. This just involves alternating 1 week of antibiotic treatment with 3 weeks off antibiotics to help prevent reoccurrence while reducing the risk of antibiotic resistance. As part of the care plan, it's really important to communicate progress in bladder training to the rehab team because it's that collaborative approach that really ensures that any decision making regarding drug therapy aligns with the patient's overall treatment goals and promotes the best outcome.